Hi everyone, I think we'll make a start. We have a very enthusiastic set of early arrivals today, and it's no surprise because today should be an absolutely terrific session. So a warm welcome to today's session on leadership for a changing health landscape. It's a real pleasure and thrill to have you all here today. I'd like to begin with the acknowledgement of country, and we're proud that Macquarie University has named our campus the Wallamadigal campus, honouring the traditional custodians of this land. And that's a daily reminder that the stories, knowledge and care of the Wallamadigal clan of the Darug Nation are part of who we are as a university community. As we come together for a conversation about leadership in health, I think it's very appropriate to start by recognising the long history of leadership, care and connection to country that's been practised here for thousands of years. So let me acknowledge the Wallamadigal clan of the Darug Nation, honour their enduring connection to country and pay my respects to elders past and present and extend that respect to all First Nations people with us today. So today's session, Leadership for a Changing Health Landscape, comes at a moment when the health sector is being reshaped faster and more profoundly than at any other time in memory. We're seeing absolutely extraordinary advances in science, data and technology, but also new layers of complexity. Workforce pressures, system fragmentation, rising expectations for accountability and value, and an urgent need to tackle inequity. And in this kind of environment, technical expertise, of course, isn't enough. Leadership, and the kind of leadership that connects across boundaries, learns in real time, and mobilises diverse systems, has never mattered more. And that's what today is all about. It's about reframing what leadership in health really means, when change is constant and when collaboration between clinicians, researchers, policymakers, business and communities is the path to lasting impact. So today you'll have the privilege of hearing from leaders who have been at the forefront of that change, and that's across government, industry, academia and practice, and who are really rethinking and reshaping how we lead innovation, integrate systems and measure what really matters. And this discussion also reflects a broader momentum here at Macquarie. As our healthcare sector grows, so does the need to build capability and to prepare the next generation of leaders who can navigate complexity with confidence and purpose. And that's the vision behind our new Master of Health Leadership, which is a collaboration between the Faculty of Medicine, Health and Human Sciences and the Macquarie Business School. That degree is designed to equip emerging leaders with insight, with resilience and with systems thinking required for the next generation of health transformation. We have many leading programs that we offer at Macquarie. I'm sure this one will be no exception. And I'm thrilled to hear just this morning that our first few students have entered that program, which is really exciting. So as we begin today, I invite you to reflect not just on what's changing in health, which we will discuss, but also to think about how leadership itself must evolve to meet the challenges that we're facing. It's now my great pleasure to introduce our Vice-Chancellor and keynote speaker for today, Professor S. Bruce Dowton. Professor Dowton is a paediatrician, clinical geneticist, molecular biologist, researcher and academic, and has served as a senior medical executive at a range of universities, including the Harvard Medical School, as well as at healthcare institutions and consulting organisations. That seems like way too much for one life. I don't know how you fit it all in. And Professor Dowton, of course, leads the university through a comprehensive and multi-dimensional strategy to secure our renown in education and discovery, based on an ethos of service and engagement. So what better person to have to speak to us today on the topic of leading through complexity, reframing health leadership for a disrupted world. So please welcome the Vice-Chancellor.
Well, thanks very much, Leonie, for the warm welcome and introduction. I have to confess at this stage of the year, I feel as though it's a bit, I should just say, I'm just a poor country doctor, which reflects my origins. But it is a great pleasure to be here with you today to offer some reflections, leading on from what Leonie has said about the evolving healthcare system and the need for capability development in the leadership realm for the health system. And I'm going to offer you a fast run through some of at least my current thinking, which has evolved over time, but also is embedded in some models and some thinking about leadership, which I don't think has evolved, but is still very germane for today. So if we just make a start here, and do I need to turn this one on, perhaps? So as we contemplate leadership in the healthcare system, we obviously have folks who come to leadership roles with their own deep set of expertise, and we always should respect that as a part of what leading in a healthcare enterprise is about. But it also, of course, needs to intercalate with the organisational expertise which is required, and often those two things are not very well matched in modern healthcare systems. And so the goal for all of us today, I think, and particularly in the development of the new Master of Health Leadership program, is to really see that as a symbiosis, as a joining up of the individual expertise, whatever the background that someone brings to the healthcare setting, with the reality of the need for deep understanding of how the organisation one works in is set up, how it works, and particularly how it needs to face the challenges going forwards. So complexity theory is vast and has evolved over time, and it does bring us to a point in time where often we realise that things are often acting as the pressures arise. The local context seems to overwhelm things, and that is a real danger, because an individual organisation must be seen as part of a wider system. And so the sort of things that come to bear are the lack of predictability, that is the non-linearity of how the organisation is working, the uncertainty, where randomness seems to be prevailing in ways that are hard to understand, and so on down the list there, where hierarchies get disrupted but have to be instantiated in some ways. But also, I believe that very profoundly, and I think Macquarie University health system is an example of this, where emergence is possible, where real innovation and real impact can happen if the stars all line up. So as we contemplate how to work with complexity, you can't read that from here, but what I can share with you is this is the best abstraction I've seen of the Australian healthcare system. And it's a figure which I've never seen reproduced. It goes back to 2016 from the AIHW in Canberra, where the centre pie is around the fundamental entities delivering healthcare, hospitals, primary care and other organisations. The next ramp over is who's actually doing that work, and the outer ring in green and grey is who's paying for it. Now that is an amazingly ridiculously complex healthcare system for a small country with a population of 25 million people and a landmass almost the size of the United States. Unbelievably and ridiculously complicated. But then if you add on to it all the other agencies that interface with that, everywhere from supply chains to regulatory bodies and the whole list there, it becomes even more a morass of complexity. And that is the construct that we find ourselves in the healthcare system in Australia today. And so as we think about how disruptors might enter into that whole complex play, we are talking about, and I apologise, this slide didn't quite work, it's around workforce challenges, around population ageing, impacts of digital transformation, funding and affordability, and so on. There are so many potential disruptors in this very complex healthcare system that the starting place for any conception of health leadership for me is to come to terms with this very simple cartoon, which is where you stand determines what you see. So the little person standing down on the left-hand side can see it's a brick wall. And he can't see a way around the brick wall because he's facing the brick wall right in front of him. How many of us have had this experience in our professional lives in the healthcare system? Every one of us has. The person on the right-hand side can see it's a brick wall, but that person can see there's a pathway to walk around to the left and there's a pathway to walk around to the right. The individual up on top is standing on a concrete block on top of the brick wall. They're all looking at the same thing, but they're seeing it from a different perspective. The new Master of Health Leadership program, in my view, is fundamentally about trying to lead a group of aspirational health leaders through a program that will get them to understand this simple cartoon, that where you stand at any time determines what you see, and being able to move your view, your visage of what is happening through multiple different perspectives. And I'm going to give you just a very small number of perspectives on that right now, just to give you a sense for your organisations about what this program might be able to offer to those coming through. And the first one is that there is no model of leadership that works for every organisation and works for every context. The middle panel at the very top there is Claudio Abbado conducting an orchestra. Down on the bottom right-hand side is Jack Welch hacking and screaming and chopping corporate USA around, and so on. There is no one model of leadership that's going to work in every organisation and in every context. And that is underpinning the need for leaders to be able to morph and shift and change their leadership skill set depending upon the organisation they're in and the context that that organisation is in at any given time. I'm going to zoom way out now. As the Vice-Chancellor of this university, I have had for a number of years the extraordinary privilege of being part of a group in the United States that met every year at the Aspen Institute. And it was a group of 50 or 60 university leaders. I was very privileged to be the only person from outside the US as a part of that group, which unfortunately folded during COVID. And back in 2014, I heard a presentation. This two-day meeting would start with a presentation by recently retired four-star US Armed Services officers, and it would be about geopolitics and the global context. And in 2014, the address was given by General Jim Allen and Admiral James Stavridis. And what I would say before we zoom into what they said was, the starting point in thinking about the world today is to come to terms with the fact that half of the population of the world, actually more than half the population of the world, is inside that circle. And that is a huge challenge. And that population is rapidly growing and more importantly, rapidly ageing. And the demands for healthcare that we see here in this country for advancing ageing are pale compared to what is happening inside that circle for more than half of the world. But Admiral Stavridis and General Allen talked about what are the big trends that are going to be true in the world in the year 2050. Where will the world have moved to? And they spoke about the shift of geopolitical power from the west to the east. They spoke about rapidly rising urbanisation. When you look back at how many people lived in cities in 1900, about 20%. How many do now? It's about 65%, and that is going up very quickly. Brings with that, in some parts of the world, major challenges. Anyone who's been to the sparkling city of Rio de Janeiro in Brazil knows this. But what they don't know is the favela in the back blocks of Rio de Janeiro. The slums, lawless violence. How do you deliver healthcare in an environment like that, where every so often, where complete control has been lost by government, the military or the police go in and try to wrestle some semblance of control back? And their work went on to speak about, back in 2014, the inevitable rise of unpredictable epidemics and pandemics. Any one of us who thinks COVID's been and gone and there won't be another one needs to think again pretty quickly. Global food security, a huge issue. Can we feed the population of the world? And rising power of networks and the digital age. I've overlaid on that my own current version of that, which is about population ageing. It's about geopolitical shifts, particularly rise of nationalistic fervour in Western democracies, growth of the emerging EU economies, climate change, and of course, in the last very short number of years, slashed across that is the impact of generative AI. So this is the big wide world anywhere that healthcare is being delivered into. So one of the things I think we have to come to terms with in the healthcare setting is thinking about organisational dynamics and how do organisations actually get put together and how are they structured to work effectively for contemporary times. Henry Mintzberg's work is old, but I like it. It is work which says the form of an organisation fundamentally needs to reflect the variability in the environment that is live, that the organisation exists in. And that is a function of the combination of the complexity and the pace of change. Complexity and the pace of change. And Mintzberg has a very elegant 2x2 which looks at, on the x-axis, whether the organisation is simple on the left or complex on the right, and whether it is stable on the y-axis or dynamic and shifting and changing. And healthcare systems largely live in those top two red boxes, historically. They exist with two different forms. The machine bureaucracy, the rather more simple environment where things are stable, or the more complex one, but it is pretty stable. In the organisational models, the right-hand panel, this is how the bills get paid. This is how the supply chains have worked. The left-hand side, the professional bureaucracy in Mintzberg's terms, is about how professions interact, how decisions get made, how influence is exerted, where you can see it is not linear, where influence and power flows both down and up. And the individuals that I think we are targeting for this master's program, whether it is in a delivery organisation or a supply organisation or a government department, are folks who have to move between these sort of complex organisational structures. The person in the middle here has to understand how both of these forms of organisations work. My concern over the last short number of years, and particularly going forward, using Mintzberg's model, is that we are moving into a time which is so complex and so dynamic. There is a real risk of moving into what Mintzberg talks about as adhocracy. Doing things for the short term, doing things in ways which will be counterproductive to long-term stability, long-term financial health, and long-term good for the organisations overall. So that's a snapshot through a little window into organisations. Let's pause for a moment and talk about models of leadership. I've had the good fortune to be in leadership roles for more than I care to think sometimes, having started in my first one in my late 20s in the United States. And I've evolved to a model of thinking about leadership which looks at, again, 4 quadrants. In my view, leadership is fundamentally about 4 things. It is about enhancing the unit you work in or the organisation you lead and work for, and that is really about defining purpose. Why does my department exist? Really understanding that and being able to tell the story of one's organisational unit or one's institution. The second area, and increasingly important role for the leader, is about making connections. It's about the power of being able to connect up people who need to work together to get positive throughput. And the model that I like that looks at this actually goes back to the 1960s in the Colombian power industry of all places. And it looks at things one has control over, things one can influence, and things one can neither control nor influence, but need to know about. And today's environment has moved very quickly away from the leader of a unit being dictatorial inside their own unit, top-down hierarchy, and demanding of everyone in the influence sphere. Today's modern organisations have moved very much towards this porous boundaries and where boundary management, back in my model, making connections, becomes a really important part of the role of the healthcare leader. The third part of my model is about interpreting complexity, the role of the leader in being able to help their people understand what is going on. Some of us saw that very profoundly during COVID, and I noticed my own leadership style changing very quickly during COVID. For argument's sake, I am a devolutionist by heart as an organisational leader, but COVID was a time when there needed to be clarity of communications, rapid fire, analyse the information, look at the health outputs every day, look at the press conferences, interpret them, get communications out. I must have communicated more during that 12-month period with my community here than I've done in the entire other 12 years of my time in this role. And that was a shift in leadership style, because my judgment then was that this was a very turbulent and complex time, and part of my role as a leader was to help my community understand what was actually going on. And the fourth part of my model is to think around beliefs and behaviours and to model them. It never ceases to amaze me in any organisation I've worked in or consulted in that leaders are surprised when behaviour is bad below them. And how often have they looked in the mirror? People are having disputes on the ward or on the floors or in the production room or in the supply chain, people screaming at each other and so on. Where does that come from? I ask myself that with some monotonous regularity, and I somehow get the same answer every time I ask myself that question. So as we flip forward then, there are many models of leadership, and that's the one that I presented to you is one that I've worked out for myself over time. It's not for everyone, and that's fine. I also like the work of Robert Greenleaf, a Canadian scholar who really wrote very profoundly many years ago again about the notion of service in leadership, that the leader is first a servant of their organisation. And my distillation of Greenleaf's work is shown here, where there's a set of organisational attributes that are thought about for the leader, the ones on the right-hand side. The top little corner here, tipping the pyramid on its side, where the person at the apex drops right down in the side of the pyramid to the very front line. This is what drives my executive colleagues crazy in this university. This is me going out every so often and buying my lunch in the central courtyard and finding a student who looks sad or lonely or happy or upset or interesting or something, and sitting down and striking up a conversation. Then I go back to my office and I call one of my colleagues and say, I was out walking on campus today and I heard that, ... And they go like this, what the hell has he come up with now? That's tipping the pyramid on the side. So the organisational constructs, but particularly importantly, Greenleaf interfaces a set of personal attributes that the individual has about the power to hit the pause button on speak and hit the on button on listen, and listen carefully and take it in. It's a lot about self-awareness and reflection. And increasingly importantly, I think it is about this almost ephemeral quality which he wrote a little about, and a student of his, Daniel Kim, wrote more about foresight. And I think foresight is going to become a really critical thing for leaders going forward. It is not about predicting the future at all. It is about the capacity to look out at the landscape, take on board multiple data sets, multiple observations, and be able to interpret them in a way which makes meaning, and to pick a course of action that is perhaps a little bit more likely to pan out than any of the others that one might have contemplated. So again, just a couple of examples of leadership on the heels of thinking about the complexity of the organisational dynamics that are going to play out. And I hope you're getting a sense here that at least my view, as I've been chatting with those involved in the launch and the development of the new program, is that the program aims to weave a very complex set of ideas and constructs for folks who will be working in this milieu to try to give them insight about how they might craft their own leadership journey as it goes forward. I want to close with a couple of thoughts about mentorship, and I do this a little tongue in cheek, really, as it was 10:30 last night, and I was thinking, how can I round this off, because I don't have a natural ending point here. And I thought, there's two different sorts of mentorship. And at least for me, and I'm sure for many of you, mentorship has had a profound influence in my professional life. The best definition of what I am calling here today real mentorship comes from a wonderful African-American lawyer, Dr. Marion Wright Edelman. Marion Wright Edelman is a wonderful lady. She's still alive, lives in Washington, D.C. Interesting lady who grew up as a daughter of a Southern Baptist African-American preacher, married a Jewish man from Minneapolis, St. Paul, and they raised 3 sons. And she founded the United States advocacy organization, the Children's Defense Fund. It's an organization that's been around for almost 50 years, essentially to plead for the rights of children in American democracy because they do not vote. She is one of the most profound speakers I've ever heard speak. I've listened to this lady in a setting of 10,000 people, and you could hear a pin drop. She is a magnificent orator. And her definition of mentorship from her wonderful book is there on the slide. And I think it's a wonderful definition. When I think about mentors I've had in my life, really influential mentors, there's really one of the most, probably the most profound one was this man, Dr. Riven Blackburn. Shown on the left back in probably the late 1930s when he was about to enter medical school 90 years ago. And he died in 2016 at the age of 103. And the profound influence he had on my life was reflected in the fact that one of my colleagues here, the Deputy Vice-Chancellor of Research, Saki Pretorius, was saying when I'm having a moan about I've got to give a talk or do something, he says, Bruce, don't worry, but you can talk under wet cement. Being invited to speak at this man's memorial service in the Great Hall of Sydney University was the hardest public address I've ever given in my life. I think I wrote 12 drafts. When I stopped and contemplated Dr. Blackburn and the incredible influence he had on the healthcare of this country, this is the man who brought much of what is modern medicine to Australia from the United States. He went as a graduate from Sydney University to Columbia Presbyterian Hospital in New York City and spent several years there under a man named Robert Loeb, who was the chairman of the medicine department there. And over the years, Dr. Blackburn introduced to Australia the disciplines of gastroenterology, haematology, hepatology, nuclear medicine, and so on. Single-handedly brought many of those disciplines to this country. And through his amazing career, he watched the evolution of the treatment of patients with cardiac failure and peripheral edema, putting needles in their legs to drain the fluid out, to where modern medicine is today in terms of managing cardiac failure, including in our own hospital here. Quite extraordinary for one person to have lived through that evolution of time. And when I think about my own career, which he had a profound influence on, it was when I think back to why I got interested in the field of genetics as a discipline. The first human gene was cloned the year that I graduated from medical school in its most simple form. The entire molecular biology revolution and cell biology revolution that influences treatment today, diagnostics, many aspects of medicine has happened during my professional lifetime. This is a profound quickening of the pace of change in healthcare. And so there's another sort of mentorship that I want to close with, and I had fun with this last night. That's real mentorship. Is there such a thing as digital mentorship? So I went onto one of the machine learning environments last night and put the title of my talk in. Reframing Leadership for a Disrupted World, talking about human-centred leadership, courageous decision-making, values-driven leadership, patient-centredness of care, and indeed lifelong leadership learning. So there to me is an essential conundrum of where we are sitting right now at the cusp of an amazing opportunity for emergence in our healthcare system here, and there are many of you who've participated in that in this room, and I'm very grateful to each and every one of you, to those we work with as partners, and also particularly as we will welcome a class in next year to the new Master of Health Leadership program. These are my thoughts for you today. We'll come back to this.
Thank you so much, VC. So much food for thought there. Systems level thinking versus adhocracy. Where you stand determines what you see. We'll be drawing back to some of these concepts as part of our panel. The importance of interpreting complexity, modelling identity, influence and connection in leadership, and being a lantern for others. So I think there's an absolute treat in store for our students that are going to be having you as their lecturer in the new Master of Health Leadership. But thank you so much for your reflections today. Please join me in thanking the VC again. So it's now my pleasure to kick off our panel, which I'm sure will be fascinating and fun and an interesting discussion. So please let me welcome to the stage our panellists. Please take a seat and I'll introduce you all. So we have an absolutely amazing panel today to talk through the topic of leadership for innovation and impact in health, and thank you all so much for joining us. On the panel here today we've got Professor Patrick McNeil, who's Deputy Vice-Chancellor Medicine and Health at Macquarie University. Patrick leads Macquarie University Health, which is Australia's first fully integrated academic health enterprise, bringing together clinical care, research and education under one umbrella, and that's a concept we'll return to on the panel. We also welcome Elizabeth Koff, AM, who's Managing Director of Telstra Health and formerly Secretary of New South Wales Health, where she led through some of the most significant system and digital reforms in the country, including through the extraordinary pace of the COVID response. Welcome, Elizabeth. Also joining us, Rachel David, who's a nationally recognised CEO and non-executive director with deep experience across policy, governance and system reform, and who's known for her insight into how ideas scale and how complex systems can be made to work better for people. Welcome, Rachel. Julie Toma, welcome Julie, is a non-executive director across Western Health Alliance, the RAC GP's Research Foundation, Friendly Pharmacies and the Barbara May Foundation, and she brings a powerful governance and community lens to how innovation translates into equitable care. Welcome, Julie. And finally, Sarah Thom, who's Chief Financial Officer at Cochlear Limited and was previously Managing Director of Boston Consulting Group's health practice, where she led work on health technology, strategy and innovation, blending financial acumen with purpose-driven leadership. Please let's give our panel a round of applause to welcome them. So let's kick off with the theme of integration, which is something that the VC touched on in his address and which I know you're passionate about, Patrick. So let me go to you. You lead an organisation that's tried to break down one of healthcare's biggest barriers, which is the divide between research, education and clinical practice. A slightly provocative question maybe, do you think our traditional academic and clinical hierarchies actually block innovation? And how have you reimagined them to address that issue?
Yeah, it's a challenging journey. So for those present who don't understand Macquarie University Health, it's because there's no other organisation that exists like it in Australia, and there's actually not many in the world. So Macquarie University Health is a health service that's owned and run by a university. So it's an integration model rather than a partnership model. And in general, academic health or teaching healthcare institutions occur when healthcare organisations partner with a university. But there's a lot of evidence that academic healthcare organisations actually deliver the best care. If you look in the US, where academic healthcare has, I'm not sure that it did begin there, but certainly the University of Pennsylvania started the first university hospital I think in the late 1800s. The top 20 healthcare organisations are all academic healthcare organisations. Not all of them started as universities, but there is certainly good evidence that the care delivered is of high quality, that the staff are attracted to those organisations, are interested in continual improvement, and if you look at the leadership of those organisations, which is what we're talking about today, they're attracted to work in those organisations. Interestingly, though, only 17% of US healthcare organisations are academic health care organisations, so they're still a relatively underrepresented model. So I think, Leonie, your question was, is traditional hierarchies counterproductive? Well, I think they are, and it touches on things that the Vice-Chancellor talked about, the complexity in healthcare, which doesn't lend itself to leadership by hierarchy. And the complex adaptive system model of thinking about healthcare and actually how universities work is helpful in understanding the influence, the network nature, the emergence, the unpredictability of healthcare. And so leadership in that situation requires a matrix approach, it requires empowerment, it requires a different set of skill sets, as the Vice-Chancellor reflected, in switching between a traditional management, hierarchical style, but then understanding how to lead in a complex adaptive system.
Talked about some of the techniques to make that integration work. What do you find is the biggest challenge in actually making that happen in practice? I'm sure something you grapple with every day.
Yeah, so look, Macquarie University Health is on a journey. 15 years, a few months ago, Macquarie University Hospital opened. And I'd say we're still on an early part of the journey. You can't create a mature academic health enterprise quickly. And if you look at ones in the US that I've visited, they're mature organisations. You can learn things, but they all started as little places. What we have done is two things. We've had a clear strategy. We've had two sets of 5-year plans. We're about to launch our third 5-year plan next year, or develop it. So strategy is one, and I'll talk about that if you like. But the second is organisational culture. An important, and look, you'll need to enrol in the Master of Health Leadership to learn a bit more, but or get your staff to enrol. But I'll give you some ideas. So strategy integration is one of the pillars that we've had as our strategy, versus partnership that I talked about. So really, either the university needs to employ the people that work in your health system, or essentially the staff who work in your health system need to feel that they're part of a university-led enterprise. Then you start to break down that, well, who's paying for this, who's not paying for that, is it my job, is it their job, which always happens Look, the terrific teaching hospitals we have in Australia. I've worked in 2 terrific large teaching hospitals throughout my career in New South Wales for 20 years. And the people are good, the leaders are good. It's just that their KPIs don't overlap sufficiently as they do in a integrated model. So integration is critical in your strategy. In our situation, we have research and education as 2 pillars in our strategy. And we do research that links to delivery of care. We have the Australian Institute of Health Innovation that includes thinking about digital health, AI in health, thinks about implementation science. The research we do links to our clinical strengths. So we deliberately had a strategy to connect our research with our healthcare. We've deliberately focused our education in our health faculty on not entirely, but a large part is about generating our health workforce and the health workforce needed for future healthcare. And we've had culture as an important strategy. So then so you've got to have a strategy, you've got to track it, you've got to monitor it, you've got to manage it. It's not a document you stick on the top shelf and leave and then redo another one every 5 years. It's got to be a living document. And then culture, organisation culture is critical. 70% of strategies across every industry in the world fail because leaders don't take account of the organisational culture. And culture is about staff understanding their purpose of why they work in their organisation. A clear purpose is critical. A set of values is critical. And values are not feel-good mission statements, again, that sit over the door and no one takes any notice of. They have to be lived. Leaders have to walk the talk. And values need to guide how the leader allocates the organisation's resources. So values are not just we're all nice to each other. Values actually determine how you use your money. And then the third thing I would say with organisational culture is you need to measure it, you need to track it. There are ways of thinking about it in a strategic way that leaders can engage with. So they will be the 2 things. We're still on a journey. We've got some things right. We've still got things to do.
Thank you, Patrick, and it'll be great for our students in the program to hear about Macquarie's trailblazing approach on this front. Elizabeth, now I'd like to come to you. Patrick's spoken and the VC also about how health is obviously a very complex system. So I'd like to ask you about change in a complex system. You've led really major system and digital transformation in government and now in industry, and I'm interested in your reflections on how you balance that tension between leading quickly and innovating quickly and leading safely and bringing along people with you. So how do you balance speed and ensuring buy-in and that change is safe, compliant and trusted?
I think one of the critical issues with the speed is it depends on the political imperative that's at hand. And I think COVID was the best example of that. Electronic prescribing predates my time at Telstra, but we run the electronic prescription service for the Commonwealth Government, and the team had been saying to the department, we could do electronic prescribing. They said, no, we're not interested. And then arrived COVID and there was a call saying, do you think you could start electronic prescribing on Monday? And we said, yes. They said, sure. I think it's a real challenge. I think it's probably too generous a term to say that we've had digital innovation in healthcare, because I don't think we have had digital innovation. We've largely gone from analogue to digital the way we perform our current services, and all we're doing is shifting to documenting electronically instead of actually using the digital levers that we need to transform healthcare. And in my mind, that's where the innovation part occurs. we're presented at a time of, as I loved Bruce's presentation, by the way, the AI overlay is actually going to change things significantly, but understandably, inherently, the clinical safety is still paramount in digital innovation, and it's getting that balancing act right to actually drive organisations through to say that we can digitise and transform, and always calibrating that against the clinical safety. But the most important thing around it, in my mind, is digital innovation is not about acquiring a digital solution. It's about an organisational change solution and a way of doing things that has to change. And as we know, that's extraordinarily hard because people don't have the bandwidth to actually often redesign things, because you're still usually doing your day job while we're trying to innovate, because resources are so constrained. And I guess my biggest concern, and every state and territory health system is under extraordinary duress at the moment, and financially, because we did spend up big during COVID, but the constraints that we're facing now, all of a sudden where innovation is really truly going to be necessary, it's potentially considered not essential to service delivery. And I understand when there's ambulance ramping and surgical waiting list and the pressures on the budget, you focus all your resources to where they need, but I think we're at risk of potentially being left behind, because investment in innovation is going to help work our way out of this. And that's why I'm watching with the NHS in particular with interest as to their 10-year plan of reform, because they've got what I call the triple jump of hospital to community, cure to prevention, and analogue to digital. But they're really, really complex when you've got the challenge of maintaining a system operationally and shifting those paradigms and models.
Thanks, Elizabeth. Fascinating. And let's ask a related question to you, Rachel, which is, why does change in the healthcare sector take so long? What have you learnt from your work at the intersection of leadership, policy, governance and system reform about that, and about how to make innovation happen quickly?
Look, I was really fascinated by Elizabeth's comments there, and I think we share more in terms of experience than just a love of black and cream check. So I'm sorry if anyone, if that's doing anyone's head in today. But just a couple of observations about, I run an organisation that does the policy and advocacy work for health insurance funds. Health insurance in Australia, just by way of a bit of background, is a semi-nationalised sector. Despite being called private health insurance, the funds do not set prices, and they do not determine the things that health insurance covers. That is done by the Commonwealth. What they can do is raise funds from private sources. But if I want to change anything in our sector, I have to line up with every other lobbyist in Australia and talk to the Commonwealth Government about it. So that's the first thing, is that there are some very significant historical constraints, legal constraints on what can happen in our sector, which is private health. The other aspect of private health is there are some incredibly powerful vested interests in the sector, but there is no one of those vested interests that really dominates. So you have private medical specialists that traditionally the community have had up on a pedestal. You have the makers of surgical implants and supplies that are often very large global companies. Then you have private hospitals, public hospitals to a lesser extent, and then you have the funds themselves. So in that kind of environment where you have really powerful vested interests that can literally intentionally throw a spanner in the works and shut things down very early, the first thing you need to do is manage expectations, and that is understand that significant change is going to take a long time. The second thing is you need the best possible data and evidence about what it is that you're trying to do. And that doesn't just include financial metrics or clinical metrics. It can and probably should include things like consumer attitudes to the system and understanding consumers' frustrations with the system. And that's something that we definitely try and do as well. Even in a sector like ours where the stakeholders can be pulling in different directions, we do try and get alignment of at least some stakeholder groups before we attempt to change anything, particularly if it's the sort of thing that can be interpreted as taking things away. And then once you've done that, you can start to map in small steps what change might look like in future. So I'll give you a brief example of something that happened in my world a couple of years ago. There's a particular technology that's used in the treatment of low and back pain called a spinal cord stimulator. And it's something that it's only really a technology that's offered in private health. It can cost anything between $10,000 and $60,000 to $70,000 per patient. For those of you who know what a Cochrane review is, there were 2 Cochrane reviews done on this technology that concluded that it's no better than placebo. And then we contributed and there was some considerable safety signals as well about the technology that were not encouraging. So we submitted a data set of 6,000 patients, just over 6,000 patients, to one of the universities to look into how they were faring, and it concluded again that this technology was not only no better than placebo, but that it was actually positively harmful. So we then began the process of working with the TGA and working with stakeholders to talk about disinvesting in this technology, which health funds by law are obliged to pay for if a doctor orders it. And in that process, there were issues that were raised in the media. It became very difficult. But the issue that I really learnt from that experience, when a whole group of medical specialists, got up on their hind legs and were, all you care about is money and you don't want our patients to have access to these things. The thing that I really learned is that one of the hardest things to communicate in change management in our sector is when you see data at a population level that says one thing, and then you're talking to a group of medical specialists whose worldview has been limited to the patient sitting in front of them. And the sort of thing that you start to hear back is, oh, that can't be right. I've treated hundreds of people with this and they've all said they're happy, right? So that's the sort of thing you get back. Well, they've all said they feel better. But what is not necessarily taken into account in that sort of conversation is, well, that person sitting in front of you might have been completely overawed by you and didn't want to upset you. So this is something I'm still learning about, but in the world of public health or population health and the administration side of healthcare, the financing side of healthcare, it's a conversation as things begin to change rapidly on the technology side that we're going to be having pretty often.
Thanks, Rachel, and a perfect example of the VC's brick wall, and where you stand determines what you see, whether you're seeing things from a system level or an individual level. Thank you for that, and that leads on beautifully to you, Julie, I think, because you've worked in rural and regional networks, so I'd like to ask you about change in areas where perhaps resourcing is limited or systems are fragmented in some way. The VC also spoke about systems thinking versus adhocracy. So as we think about, systems approaches versus locally nuanced approaches, what have you learnt from your experience about balancing those?
Yes, I think last night you mentioned that you grew up in a regional town as well. I grew up in Tamworth, so very, very passionate about remote and regional communities. The foundation is really about building trust, relationships and clarity of purpose. And I think regional communities and clinicians have a really deep local knowledge and commitment to the area. And so really capturing and embracing that in the journey with co-design and place-based solutions. I was at the launch of a Medicare mental health centre in Parramatta and one in Dubbo, and a couple of months ago I was visiting Wilcannia, where they're wanting to put another centre in, and it needs to be very, very different in a very small regional town, hours out of Broken Hill, a long way from anywhere. So I think really listening to communities and working with them very early in that journey, and being able to adapt to those environments is really, really powerful.
Thank you. Thanks, Julie. That's fascinating. Let's move to you now, Sarah, and you bring a strategy and finance lens, which I think is useful to bring in now. So from your perspective of leading those areas at Cochlear, how do you decide what to invest in? How do you think about ROI, risk, impact when you're fostering innovation?
Well, we think about it all the time. Absolutely. For those of you who aren't familiar with cochlear implants, they are a surgically implantable device that can return your sense of hearing. They work for people when you are severely to profoundly deaf and when hearing aids are no longer enough. And the interesting opportunity in this is that when we look at the potential number of people that we could help in the world, if you look at those people who are clinically eligible to benefit from a cochlear implant, right now only 4% of those people have a cochlear implant. So we have an enormous growth potential, and our mission is to help more people hear and be heard. And so all of the choices we're making, there's lots of good options, right? But strategy is deciding which good options not to do. And so we do have to think about that from a what would it take to actually deliver, how could we actually achieve the most value to consumers, and honestly the most value to society. If you look at the people that got cochlear implants, 1 or 2 cochlear implants in the last year alone, that's 50,000 people, and the total societal benefit over their lifetimes is $8 billion. If you look at their ability to access education, their ability to access employment, we also know there's research that has continued over the last decades to more closely link hearing loss and cognitive decline. And so looking at that in the whole picture absolutely indicates there's opportunity, but it is really hard sometimes to make the decision about which opportunity to chase. Now, Cochlear is built on its foundation of having an amazing technology, a physical product. And we still manufacture that physical product a lot, just right across the street in our facility here in Macquarie. We have other manufacturing, but the heart of it is done right here. And the thing is, we can help more people hear by bringing better products to market that work even better for people, and making it even more and more interesting to a consumer. You know, when we first launched the cochlear implant many decades ago, you had a big device that you wore kind of at your hip. It was big and bulky and you could hear, but there were downsides to that. And now the device is much, much smaller. We have the smallest device on the market. You know, we know that that's really, really important to a consumer in the decision to get a cochlear implant. You know, of the people who actually engage with a medical professional and know that they are clinically qualified to get a cochlear implant, only 1/3 of those people end up getting surgery. It's a very big decision. And so we also think about how do we help more of those people feel confident to get surgery? How do we help more referring professionals refer someone on to a surgeon who can help them learn more? You know, a lot of people realize that their hearing is a real challenge for them, and it may be an audiologist in a, Main Street hearing aid shop who can refer them on to get a investigation with a specialist ENT surgeon, or a GP might do that. But we don't actually engage with those professionals very much. So we also have innovation opportunities, not only on the product side, but on the commercial side. How do we help referring professionals better understand the opportunities and the life benefits that somebody gets when they can access a cochlear implant? So when we're thinking about innovation, it's not just purely in where do we put R&D dollars into the product. It's about how do we change the capabilities of our sales force. It's about how do we think continually around making sure that we've got the right level of cost of producing these implants so that we can make sure we bring more affordable products to market as we go. So there's a lot of different aspects, and absolutely every single day we talk about this. Being in a listed business means that our financials are very public. It means that our corporate governance is very public, right? The way that we incentivize people in our business, we've got a very clear structure. It's about delivering financial results, and it's about achieving strategic priorities and the work we need to do toward advancing those long-term strategic priorities. And so when we're making these choices, it becomes very obvious to investors, to analysts, to anyone who wants to read our annual report, how we're going on those dimensions. And so we have an absolute obligation, not only because we want to help more people hear and be heard, but in the end, it's very public.
Thank you so much, Sarah. Let's now touch on some cross-cutting themes that I'll direct to the whole panel, and I'll start on fostering impact. So I'm very keen to know your reflections on how we set up systems and structures to genuinely drive the outcomes that we want, the impacts that we want to see, instead of merely reporting, for example, on activity. And Elizabeth, you've been passionate about leading some of Australia's biggest moves on excuse my croak, value-based healthcare, so perhaps you can kick off.
COVID got in the way of everything in my mind, but value-based healthcare was one of my passions because critically productivity in the health sector has been pretty stagnant. Most of the productivity is derived from new technical medical procedures rather than actually the way the business is conducted. And part of the most recent productivity report identified some areas that would really benefit in enhancing the health system delivery. One of the critical issues in my mind, though, talking to clinicians about productivity, they will glaze over. And it is rather an economic term, and productivity and efficiency do not resonate with clinicians, let's be honest. Many told me across my career lifetime that if I'm not going well over my budget, Elizabeth, I'm not doing my job well because I'm not treating enough patients. And I still remember when we used to restrict cochlear implant numbers because we didn't have enough money to meet the demand. That this is the issue that you really need to consider, that if we're going to explore the brand new world of genomics, if we're going to have wonderful new things on the horizon, how does the health system afford it without just saying, give us more money? Because that is the constant mantra. We need more money, we need more money. I always felt as steward of New South Wales Health that I had a responsibility to ensure the resources are being allocated appropriately and effectively, and it did represent value for money. So value for money is about value-based healthcare is about measuring the patient experience and measuring the patient outcome, because you need the two to go hand in hand, the clinician experience of delivering that care and the actual cost of delivering care. So we embarked on, and it's really hard to shift a system. I don't think we got there at all. Consistently across the state, but it's identifying those no-brainers in my mind where there is strong clinical evidence for doing things in a different way that the system actually should adopt. And one of the ones I remember most distinctly is the renal palliative care, because everybody sort of thought dialysis is the only option, but we had some renal clinicians, and this is where leadership's critically important. I couldn't put out an edict that said you have to change your clinical practice to do it that way. It's about engaging the clinicians, seeing what the contemporary practice is, how you can shift the model of care and make a better experience. So it's hard, but I think it's critically important. But measurement and transparency about that data and incorporating the patient experience and measurement of the outcome are all part of the coherent response to having impact.
Can I build on that? I absolutely think that what you're saying is spot on, Elizabeth, and I think it's a really important point about how do we, from different parts of the ecosystem, work together on that. From a cochlear perspective, when you get a cochlear implant, you need to learn to hear with that cochlear implant, and so you work with an audiologist in your first year. Now, there is research showing that most of the benefit of getting used to that happens in the first 3 months. But we know that patients see their audiologist many times, often in the first year and often into the second year. The model of care is very non-standard. Some audiologists will see patients 10 hours in the first year. Some audiologists see patients up to 30 hours in the first year. And the clinical capacity that is taken up with seeing patients for some of those patients absolutely is the right thing. There are some really complex patients. But for a lot of patients, we know that we observe audiologists in some practices able to shift to a much more streamlined model of care. And one of the things that we found is, to your point about data, we can share back data from our software systems where we can look at 100,000 patients and say, look, here's how much time you're spending with them, here's what they're able to, here's what you're actually doing with them or not. And having those conversations with audiologists and supporting audiologists who have kind of pushed harder on how do we get the really right model of care to talk with other ones who are finding it harder because of the funding models in their systems or the other constraints they're facing. I think there's a huge partnership about how do we actually get to what can really work best so that you can effectively treat more people and get that clinical capacity where it's needed most.
If it's okay, I might endorse that with a further comment. One thing that we're seeing a lot of now, that technology is changing so fast, is that the technology is changing faster than anyone can adjust incentives or adjust some of the legacy infrastructure to be able to follow it. So there's been a big change. I'll give you one example. There's been a big change in the way that clinical psychiatry is practiced in the community, which has occurred as a result of COVID dramatically accelerating some trends that were already there. So the psychiatrists are people with moderate severity disease and addictions which don't require medical detox are increasingly treating people by telehealth in the community and not admitting them to private hospitals anymore. So there was a recent episode of a hospital closure that was all over the media in Hobart. The Hobart Clinic, a 27-bed hospital, and when we looked into it, the occupancy was right down, and the majority of patients that used to be treated there are now being treated by psychiatrists who live in Melbourne, who are seeing them by telehealth. They have e-scripts, and so that this previous cohort of people are simply not being treated in hospitals, yet we have all of this legacy infrastructure. There are still some standalone mental health hospitals that are under construction in the private sector, but the community expectations in terms of people seeking their own mental health care online and the behaviour of the key clinicians has just moved on.
Thank you. We've talked a lot about complexity in the system, the changes, the external changes that are impacting the system, and how we affect change. So I'm really interested in the panel's reflections on what is really critical in our next generation of health leaders. What are the leadership skills that are really critical for the context that we're in? Julie?
Yes, I think the Vice-Chancellor touched on this earlier. I think it's incredibly important to bring collaboration, really good listening skills and diversity of thinking to decision making. And I think that humility and that servant leadership that was mentioned earlier is really critical, because when the pace of change is happening at an increasing rate, the traditional hierarchy and top-down decision-making is not going to help us adapt as quickly as we need to.
Yeah, well, we need leaders in the health system who've done the Macquarie Master of Health Leadership course. No, I mean, I'm seriously, I think it is a terrific course. I mean, I'm actually teaching it. Professor Dowton is teaching it. Many of the people in this room are actually teaching it. It is a course that is taught by both academics and industry leaders, people who are already leading healthcare. And so I think it will be a different course. This is a bit of an advert, Leonie, but and it's probably the only Masters of Health Leadership in Australia that's run out of a business school, out of one of the best business schools in Australia. So. But in a deep collaboration between the health faculty and the business school. So I think it'll really provide leaders with a set of capabilities that will be quite unique. I'm a great, I believe passionately that that clinicians actually do make good leaders in the health system in a way, but they have gaps. I recently read a great article, Mark, from Colin Goldschmidt, who's recently stepped down as the CEO of Sonic, a clinician, a pathologist, and he talks about in that article about proving the kind of doubt is wrong that clinicians can actually be good leaders. But there are some other skills that business people actually know that we clinicians don't know anything about. A whole area of capability that will bring a lot of strength to leadership. So there's different ways of looking at it, but I think this is an opportunity. Getting back to not selling the Masters Health Leadership, what I would say is, as we've heard, change is just normal. I mean, I know it's a cliche, but change is not only the new normal, it probably has always been the normal. And leaders, you do need leaders who are comfortable with change. Some leaders are not comfortable with change. And leading through change and innovating continually is an interesting area that I'll be teaching on that if you want to enrol in that unit of study on leading through innovation. But it basically, and I touch on some learnings that I've learned from Harvard Business School leaders in courses I've done and through my own experience, is that most innovations, if you think of the great innovations in the world, have rarely come from a single person. Even if you think of the great inventors in history, when you dig into the details of how that invention occurred, it has generally been a group of people. And so there's some work that Harvard Business School have done looking at relatively contemporary companies that are able to innovate, not just once, but over and over. Companies like Google, companies like Pixar. And what they found when you look at those companies, the leadership is not about the visionary leader with the great ideas. It is about a leader who creates an organisation capable of leadership, a willingness to innovate, capable of innovation, a willingness to innovate and a capability to innovate. And that's, you'll have to enrol in that unit if you want to learn more. But it's really a particular type of leadership that fosters innovation and enables change. So that is one element. I would say the other element is the use of data. And I'll give you a couple of examples. When I was on the leadership of a big public hospital in southwestern Sydney, I had access to the Bureau of Health Information, New South Wales, BHI, data. And I couldn't believe the data that I could, I don't know how I got access to this, but I could see almost every patient in every hospital in New South Wales and which doctor they were under. This data was here. You could have generated reports and shared it. And it seemed to me at the time, this was quite a while ago before I came to Macquarie, that there was a sensitivity about publishing data because, identify individual doctors, ... But that's a huge enabler of change. And then I take another example in our own hospital, Macquarie University Hospital. We thought we needed to build some more beds. And then we did a project on variation of length of stay after knee replacement and hip replacement. And we got that data pretty easily because we've had an electronic health record in the private system since we opened. And it really showed quite a lot of variation. And when you present that to our group of orthopaedic surgeons, they didn't want to be the outlier. And we de-identified it. We had some, ways of talking about it without kind of embarrassing our surgeons. But very quickly, we reduced our length of stay by about 2 days. Now, that opened up more than 30 new beds. We didn't need to build 30 beds to expand a hospital. We just needed to use data to change practice, which was better for our patients, better patient outcomes, and better productivity. So data, we need leaders who are very willing to use data and use the data for change, for benefit.
Thank you, Patrick. It is indeed going to be a fantastic course. You've convinced me to enrol. Okay, let's move now to a few rapid-fire questions to the panellists, and I'm going to give you a lovely scenario that you wish was true. If you had $100 million to invest in health innovation, tell me where you're going to put it and why.
I'd put it into translation, and I'm also really, really passionate about the impact first 2,000 days can have in improving the health and well-being for the remainder of their lives. So that would be where I'd put it, translation. So connecting clinicians, researchers, funders, etc., to really turn some of the great ideas that we see coming out of Australia into real life outcomes.
I would put it into IT systems, basically, so that everyone in the ecosystem is linked and they have access to the data that we need to facilitate change. And if I didn't spend all of it doing that, then I would use some of the money as direct funding to incentivise clinicians and hospitals to move with the times and adopt the latest evidence, putting it into practice.
I would draw from the I would turn the mic on first. I would draw from the experience of how Cochlear got started and what supported its initial development, which is putting money into development and commercialization of products, but with a requirement that the researchers who are involved in that are partnered with a big business who's got the know-how to do it well. Right? Cochlear came out of research done down in Melbourne, and it was able to access money through the government that came with a requirement that it had to have a big business involved. And it partnered up with what was then Pacific Dunlop. And that's why it ended up here in Sydney. And it was the know-how of Pacific Dunlop with pacemaker technology, another implantable solution. It wasn't because they knew anything about cochlear implants, right? That was brand new. But how do you actually bring something to market? It takes a really long time and a whole bunch of different aspects of understanding that product and the innovation really deeply, but then also understanding the market and how you commercialize. So I would put money into scaling up the really awesome know-how and research that we have here in Australia, because I think we can have lots more businesses like Cochlear helping people.
So $100 million wouldn't be enough to do much, but if that's all I had, I would put it into integrated care. I think one of the difficulties, as the Vice-Chancellor showed in that lovely figure, is that our health system is so fragmented. Our patients have great difficulty navigating it, and there's gross inefficiency and poor care and low value care. There's a whole set of kind of downsides of care not being properly connected between primary and secondary care, between ambulatory and inpatient care, across disciplines, because professions guard their territory. And so integrating between all elements is projects that I think will be very worthwhile.
We need data sharing. That's going to be the foundation for everything. When I think of all the things that most people have said, you could actually achieve most of those things if there was common data sharing and repositories of data. Everybody's talking about AI, and I'm rather curious about why everybody's talking about AI in healthcare, because we don't share data, or our data systems aren't that well defined. And that's going to be the basis of all future transformation in my mind, no matter what the specialty area, no matter whether you want to integrate care, no matter whether you want the first 2,000 days. Everything's predicated on understanding the care and connection points across the whole of the health system. So that would be my strongest plea. We couldn't do it in New South Wales Health. Prior to COVID, I undertook a special project to see if we could create data lakes from the population health, from the medical record, from somewhere else. Everybody was so protective of their own data and didn't want to share and reluctant to share, and we're never going to go anywhere while we've still got those attitudes. And if you think of it on a national level, it's extraordinary. We've got lots of data, we just don't know what to do with it, how to access it.
Thank you all for that. I'm sure there are pressing questions in everyone's minds, so we now move to the Q&A. I think there will be some roving mics. Please raise your hand if you've got a question for the panel.
Hi, really good presentations. I currently work in healthcare. My role is in mainly communications and marketing, so it's improving the patient experience end to end, trying to connect business and clinical. So my educational background is finance and marketing, and I was wondering, with my background and where I'm working now, would I benefit from the Masters in Healthcare Leadership?
I think we better go to Patrick.
Yeah, look, definitely, and I would say, I would say if you're very interested in the patient experience, that has to be much bigger part of our health system. You know, our health systems around the world are designed by the providers of healthcare, when they should be designed for the receivers of healthcare. And we've heard examples of how difficult it is to change, make a change, even when you've got evidence, because the providers of healthcare have got an incentive to maintain the current system, even when the evidence is that procedure is not helpful. So getting patient-reported outcomes, getting the patient experience more into the system, I think is critical. So if you're interested in the patient experience, you've got a communication and your skills, you would definitely benefit from the Master of Health Leadership.
Something I do struggle with is getting the clinicians to agree to do the business side of things, and I totally understand your point of view. So I think, I would benefit from maybe. I'm definitely considering it. Yep.
There's a theme that's come up about, fostering change in the absence of external pressure, and you spoke, Elizabeth, about how COVID was actually very helpful in fostering innovation. We certainly related to that at the university, where we rapidly moved to online learning within 5 days, and normally that might have been a 3 or 4 year process. So I'm interested in the panel's reflections on fostering change without that external pressure. How do you lead to do that?
It's a lot harder. If there's not a burning platform, there's a reluctance to actually engage. Why do we need to change? What's the reason? Everything's fine as it is. And it takes a significant investment and cost of people's time and energy to actually redesign things and know the way they could be done differently. So I think part of the critical issue, as Patrick defined, though, is to be quite clear at what the strategy is, because if you can demonstrate some alignment to what the strategic imperative is, and invest in that, because one thing that I've learnt across the years too, everybody loves a strategy. Strategy is the easy bit, the implementation's the hard bit, and how it doesn't get left on the shelf, as you described, is part of the challenge, and it takes constancy of effort and perseverance and measurement and reiteration and delivery, and then rewards and recognition for success in those areas, and it is quite a continuum that you have to go on.
I found with this in business that creating leadership that really lives and breathes curiosity and collaboration really instills that energy. Because if you're working in an environment where everyone's tired, they're working long hours and things are inefficient, if you can really empower people to come up with wonderful ideas and be part of the journey of innovating and making things better and easier, it's very inspiring for staff, and it creates a culture that's really builds on that, and also creating an environment where people are able to test and learn design thinking, and being able to fail and fail fast occasionally. A culture where people aren't ever allowed to fail is going to kill innovation, and does. So I think the combination of that.
Thank you, Julian. Elizabeth, I think we've got another question.
Hi, Bettina McNeil from Health Direct Australia. Loved hearing the conversation about transforming at scale and a system, and Rachel was really interesting hearing that experience, because I saw it play out from the outside in the media about individual doctors and stories of patients versus an institutional sort of response. So really interested in, I'm thinking about how do you use data, because that's fine, that will convince the policymakers, but a story and a patient and wheeling kind of someone out as the face of it seems to be the thing that captures the hearts and minds. And Greg Hunt used to do this really well. I watch leaders do it and I try to think about what's the strategy. I'd love to hear any other experience or observations you have on the combination of storytelling with data to affect system change.
I might start on that, because I think you've correctly observed that particularly the Australian commercial media loves a case study, and that can be a really good way of highlighting an issue to, not just our political leaders, but to the rest of the community, particularly if it is something that concerns community safety or access to healthcare. And I think it is a terrific way to communicate. But I think something that's almost as important, picking up on what Elizabeth said earlier about integration of data, is you need to look at the right way to give people feedback if you actually want change to occur, particularly if you are in that situation that I referenced earlier, where you have a clinician that might be, they're a medical specialist, they're highly focused, they've got a huge amount of knowledge about a particular defined range of things, and all they're seeing is that one patient in front of them that they're trying to help. How you give feedback about what's going on more generally, whether it's about clinical trials, evidence, whether it's about how much they're charging and how much the length of stay in hospital their patients have, and whether or not they're an outlier, that is an extremely important part of the process. And you really need to work out how you target feedback to different parts of the system, who delivers it in particular, and once people have the feedback and start to adjust their behaviour, what you're going to do to help them change. And that can sometimes be things like changing financial incentives. It might be something like changing the environment in which they're working.
Yeah, and I think you need to think about telling the right story in the right way to the right audience. At Cochlear, we've always been very customer focused, but in a bunch of recent years, we've talked about, well, what do we mean by customer? Who is our customer? We have recipients who already have a cochlear implant, but then we also have candidates who might get a cochlear implant, but then we have the professional who does the surgery. We have the payers, who might be a private or a public insurer, for example. We have the provider, who is the hospital in that case. And then we also have policymakers. And there is a story about our, perspectives that we've learned from patients about the value that these devices make in their life and how that can help, them in both their own lives and kind of the broader economy. But how we tell that story depends on who we're talking to. I think with all audiences, it really does come back to the recipient experience. But in some cases, it's the surgeon experience, or in some cases, it's the audiologist experience, and understanding why that's actually really helpful to them and how they see that creating broader benefits is important.
Maybe I could just add, I think storytelling is a pretty critical skill for any leader. The Vice-Chancellor talked about interpreting complexity for staff, particularly in times of crisis. And stories are very helpful in explaining complexity to your staff. And as a leader of an organisation, you can't achieve anything without your staff engaged, and that's about the culture I talked about, organisational culture. So your storytelling is a critical skill of any leader. I'm not a natural storyteller. There are terrific storytellers who are great leaders, but it's a skill that you purposefully need to develop.
And for your shareholders.
I was going to also mention storytelling. I think it's incredibly powerful way of communicating, and people will make decisions based on their emotion and then justify it with evidence and fact. So if you can communicate your story of your organisation and what you're achieving through the lens of someone's mum, someone's child, someone's sister. It can be incredibly compelling and powerful.
Thanks. It's Michael Boyer from Chris O'Brien Lifehouse. I'm really interested in the panel's view of how much of leadership and change in the health system is kind of internally driven from the health system, and how much is responding to the expectations of patients and the community more generally. Because it strikes me that there is actually quite a big mismatch between what we think should happen and what the community expects.
And that's part of the problem too. We don't have a good dialogue with the community as to their expectations around what health services are delivered and how they're delivered. That played out regularly in my tenure as being Secretary of Health, where I remember back in the day, that's how long I've been in health, every hospital wanted a linear accelerator and a comprehensive cancer centre. We need one. Why can't we have one? Every hospital wanted a cath lab because somebody felt they were travelling too far. The conversation needs to be had as to what can realistically be offered. And you look at the pressure of election announcements and all we're doing is building hospitals. And there is pressure and bed demand and all those other sort of things going on at the moment. But you get pincered between what the community expectation is and the political expectation. And I think you're really wedged between the two. Oftentimes before elections, government, irrespective of the persuasion, will come and say, what do you think we should do in terms of funding enhancements? You've got to realise too, every year on year, every budget increase usually the bulk of it goes in salaries, and there's very little left for anything innovative. And we used to put things up all the time that would start shifting the dial, that we consulted with clinicians. How can we change this? What do you think we could do? How do you think we could do things more differently? And at the end of the day, the government will decide and it's their prerogative. They're the elected government. But one very frustrating time, sorry to drag this one on, was the government of the day wanted something that would excite and delight the community. That's what we want. You know, we more surgery, no. We more this, no. Palcare, no. We want something that's going to excite and delight the community. So the baby bundle was born, and as a long-standing health executive, knowing where your need is to actually give, and as a newborn mother you'd probably love a baby bundle, but was that the appropriate use of expenditure of millions of dollars when you're under pressure? For those who have got a baby bundle, I can see heads nodding. They might have been good, but here am I grappling with a baby bundle for every newborn that doesn't shift outcomes, doesn't make a difference to the system, versus where you could have invested the money to make a real difference to health outcome. But that's the reality of democracy. And whilst some leaders, and this caused a real tension in terms of our executive, that they said this is wrong. I said it may be wrong from your perspective, but I said it's not illegal. So let's be clear, we're not endorsing anything that shouldn't be done. It's the government's prerogative, and you've got to know when to stand your ground on things that the government wants to do that are not appropriate, and fight your fights. And at the end of the day, the baby bundle is there. So enjoy.
I might add something to that as well, and it's to do with the consumer expectation piece. Technology is changing this very rapidly. We've now got people seeking out particular forms of care. They're self-diagnosing, or at least they're coming up with their own differential diagnosis through things like AI and TikTok and Instagram. They are proactively seeking care that they're hearing about from health influencers in those forums, and that may or may not be something that's clinically appropriate. So, I mean, my warning would be, having seen what's evolving and happening in mental health, is that one thing we need to do is to really invest some time, money and effort in not stopping this, but ensuring that people get on the right track. And particularly when you've got the stuff coming out of the United States, you know, the horseshit about Panadol and autism and, you know, and so forth, you know, it's going to get harder.
I'd agree that investing in health literacy and AI and access to help consumers make better and more informed decisions and be more empowered to be in control of their own health and wellbeing journey is going to be incredibly important in making the health system sustainable.
I also think it's really interesting, how do we think about having consumers who are more involved in their own health understanding, their awareness is growing, their opportunities to differentially diagnose themselves are increasing for their own selves. How do we help them know how to navigate our complicated health system? I mean, we were health professionals and we find it tricky, right? I think about something like Apple's innovation with the AirPods, where you can you can do your own hearing test. And then what? Right? Like, I love that Apple is doing this. I love that they're raising awareness about hearing is something that's really important. You know, people feel very comfortable if you get glasses when you can't see very well, but there's often a real stigma around getting a hearing aid or pursuing different outcomes or opportunities like a cochlear implant, if that was right. But how do we help people know how to navigate and know where to go and make that easier? Because it is, even if you had all the data, even if we were really integrated, it's just really hard to navigate.
Well, thank you all so much. It's been an absolutely fascinating panel. I think it's safe to say you've excited and delighted our community here today. So please join me in giving our panel a huge round of applause.